Okay, so I know that I mentioned in the last slide that we don't actually do the picking out of the valves. And that is 100% true. We do not. We do not, as baccalaureate prepared registered nurses, in all of our infinite wisdom about a lot of stuff, have enough wisdom about what valves need to go where to be able to help anybody pick out valves. That's somebody else's job. What do we do? So nursing management of valve failure. Here is what we do. We are going to be gathering in our assessment some subjective data, including past medical history, any fatigue, palpitations, weakness, inactivity, intolerance, dizziness, fainting. Do they have any cough? How are they breathing? Do they have hemoptysis? Are they coughing up blood? Orthopnea, that paroxysmal nocturnal dyspnea. Are they having any angina, any chest pain, any angina, chest pain? We're going to gather objective data like fever. Are they sweating? Do they have diaphoresis? Are they flushing? Do they have cyanosis? Are they red? Are they blue? Do they have clubbing in their digits? Do they have peripheral edema? How do their lungs sound? Do we hear crackles and wheezes? And how does their voice sound? Do they have hoarseness? Do we hear S3 and S4 or one of those? How does their EKG look in terms of their dysrhythmia? We will take a look at pulse pressure, take a look at hypotension. We will look at their peripheral pulses. Do they have pulses that are just like boom, 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 or do they have really thready ones that are just really fickle? How's their liver? I know that I talked a lot about in heart failure about how heart failure impacts the liver, and valve failure creates heart failure, which creates liver failure, downstream effect. Do they have any ascites? How are they? Ascites indicates how well they're able to move blood out of the abdomen, and it indicates how well the liver is functioning overall. Are they gaining weight? Again, heart failure patients, we're always looking at their weight. And when it comes to the diagnoses, the primary diagnosis associated with valve failure is impaired cardiac output, because either there's not enough blood coming through the valve to start out with, or the blood is not having anything to like push against when it's being moved, and it can move back and forth back into the heart rather than just moving one direction through the heart. We end up having like two-way streets instead of one-way streets. Can create activity intolerance. Sorry, I'll get all my syllables in there. Could also create fluid imbalance. So for these particular clients, when we're doing our plan, we want to make sure that they're trying to get back to as normal heart function as possible. We're going to improve their activity tolerance, and we are going to seek out an understanding of the disease process and health maintenance measures. When people understand the disease process and when they understand their health maintenance measures, they're more likely to adhere to said interventions. So let's take a look about how we implement that. So we're going to be implementing that in a few different ways. We're going to be using health promotion. So one of the main causes of valve failure is Streptococcus infections. One of the main Streptococcus infections that really gets beaten up on that heart, dental abscesses and strep throat. So stuff that's happening in the oral cavity goes down, travels, comes out of the heart valves. Prophylactic antibiotics can be used for patients with heart valve history for this reason. And then we're going to be teaching patients symptoms to report. The other thing is, and this is something that the book doesn't cover, but this is something that I've seen in real life more than once, is illicit drug use makes you more likely to have problems with vegetation growing on your heart valves. Vegetation growing on your heart valves can create stenosis and or regurgitation as well. So quitting the illicit drug use will help out a great deal as well. Patient teaching, we're going to be working with them on the prescribed drug actions, side effects, the importance of prophylactic antibiotic therapy, the information relating to any sort of anticoagulation therapy, especially if they have one of those mechanical valves, like in their going home on warfarin, they're going to need to know how to administer their warfarin and how often they're going to have to go to Coumadin clinic to be able to get their INR checked. And I know we talked about a lot of different anticoagulant drugs when we talked about DVTs and what sort of things they should be looking for if they've got too much anticoagulant on board, bleeding gums, bleeding in the urine, bleeding when they wipe from number 2. When to seek medical care is basically what that all rolls into. Individualized rest and exercise routines. These people, just like the heart failure people that I talked about earlier in my day today, but in the heart failure slides, we want to be able to cluster their exercise and maximize that. And then so they can maximize their rest too. Avoiding strenuous activity, discouraging tobacco use, ongoing cardiac assessments to monitor drug effectiveness, like Coumadin clinic, and then monitoring that INR for patients on anticoagulants, again, at Coumadin clinic. So implementation, we will be needing to get them into some follow-up care. This is not necessarily a one and done sort of situation. We need to teach them the signs of infection, of heart failure, of bleeding, and to notify their healthcare provider. The other thing is that they need to have some dental work. There's some tricky business that needs to go along with their anticoagulation therapy. So before they get dental work done, especially the invasive dental work that's planned, like perhaps they need to have an extraction or a root canal, they need to work out with their primary healthcare provider about their anticoagulation therapy so that they can have a successful dental surgery too and not accidentally bleed out at the oral surgeon. Also, these people who are on anticoagulation therapy should have some sort of medical alert device or bracelet. I found this picture on Amazon.com. By the way, if you search medical alert bracelets on Amazon.com, they have some really, really pretty ones. They're not all really just very functional, and sometimes there's pendant necklaces, there's all sorts of different things. You can be as vain as you want to and still wear your medical alert jewelry. And then when it comes to evaluation, our expected patient outcomes for people who have had interventions for their valve structure is we want to maintain adequate tissue and organ perfusion. We want to achieve fluid and electrolyte balance. We want them to be able to achieve their optimal level of activity. The more often they can move and be active, the better off they're going to be. And then we want them to describe their disease process and measures to prevent complications. So these are our expected outcomes of people with heart failure. And that's, or not only heart failure, but with valve failure. So I'm going to stop sharing because that's my last slide. These are going to be posted onto YouTube so that you can access them whenever you want, however long you want, however many times you want. And I will see you in class. Have a great day.